Thank you all for attending this morning's Grand Rounds. Today I'm going to be talking about multiple ideas regarding deprescribing and polypharmacy. And so I first want to talk about the intersection between multimorbidity and polypharmacy, as this is a major issue in our older adults. We'll also talk about causes and consequences of polypharmacy, employ strategies to reduce polypharmacy, and really, hopefully at the end of this presentation, you'll be able to identify opportunities in your own practice for deprescribing to optimize care and minimize harm in your patients. Now, really, the first thing I wanted to talk about is multimorbidity, because this is a major challenge for those of us with geriatric patients. This is defined as having 2 or more medical conditions lasting more than 1 year. And so naturally, for our patients who have morbidity, which means multi-conditions, many disease states, this leads to complex care. And so there are a lot of sequelae that can result from multimorbidity, and that can include drug interactions, drug-disease interactions, therapeutic competition. When you give a beta blocker for heart failure, that in turn can worsen their pulmonary disease. Other sequelae include efficacy and toxicity, challenged by life expectancy. And we'll talk a lot about life expectancy and time to benefit in this talk. But an example of that would be statins. Is your patient going to live long enough to achieve the benefit of a statin or a particular drug? As a patient ages over time, they're going to have altered clinical presentations, altered pharmacokinetics and pharmacodynamics. So this is going to lead to adverse drug reactions, more drug dosing challenges. And so all of these things can result from patients who have multimorbidity. Now, this is a great illustration of the complexity of care with a patient with multimorbidity. And I'll highlight one example of how multimorbidity can really lead to this complex care. So let's start with a patient who has osteoarthritis. And for that osteoarthritis, they're given an NSAID. They're given ibuprofen. But that ibuprofen now is going to exacerbate their heart failure that they already have. And then it could also cause worsen their chronic kidney disease or cause chronic kidney disease. So you can see that there's this cascade with one condition interacting with other conditions and other medications and so on and so forth. So you can see this mass spaghetti diagram of all different kinds of interactions that can happen with our patients with multimorbidity. So it's important, as your patients age in the World Trade Center clinic, that they're going to start developing other conditions, and they're going to be getting other medications with that. And they're all going to interact with each other. So it's important to look at them as a whole and not as single disease states. So the American Geriatric Society developed some guiding principles for the care of older adults. Now, they point out that this is not a guideline based on evidence-based randomized controlled trials. There's no strength of evidence designation, and there's no hard recommendations. And that's because geriatric patients, one patient is one patient, right? Everyone's individual, and their care can be varied. So they've come up with these guiding principles to provide flexibility for you as a provider. And they want you to think about these things when caring for these older adults. So the first principle is patient preference, and we should be including this in all of our decision-making when we're caring for our patients. Does your patient understand the risk or the benefit of the particular medication? This is really crucial for them to develop a partnership with you in their care. The second guiding principle is interpreting the evidence. When you're looking at the literature, is it considering, are there older adults in the study? Are they looking at absolute risk reduction versus relative risk? Are they talking about patient-oriented outcomes versus disease-oriented outcomes? And these are all really important things to think about when we're looking at the evidence. When we talk about prognosis, you're going to have to frame your medical decisions within the context of risks, burdens, and benefits, and functional status, life expectancy, and so forth. You want to think about the complexity of the regimen you're suggesting. Is it feasible for the patient to take it? Can they afford it? Is it too many times a day? Are they going to be overwhelmed? And so here we're going to be thinking about polypharmacy. And then the fifth guiding principle is optimizing therapies and care plans. And what I've listed here are different tools that can help you optimize drug therapy in your patients. The guiding principles document mentions Beer's criteria, the start-stop criteria, medication appropriateness index, and then I've added my own hierarchy of medication evaluation, which I'm going to show you in today's presentation. But all of these are tools to help you deprescribe, to help you decide how to avoid inappropriate prescribing and really move towards rational prescribing for your older adults. So the term polypharmacy is, there are so many definitions of polypharmacy. If you do a search, you will get a million hits on this topic. And in fact, there's at least 111 definitions as of when we did part of this presentation a year ago, and there's probably more. But you can see that it's been studied in the literature, but there's varying definitions of it. But the most commonly used definition is more than five or more medications. But really, it's any amount of medications that your patient doesn't need. And so what we're talking about today is how can we avoid polypharmacy, or how can we use deprescribing to really shrink the number of medications that our patients are on. Now, in a large study, it was called the Sloan study, and this was looking at the medications, how older adults are taking, how many medications are they taking, and medication usage in the United States. And what they found was that almost 60% of older women take more than 5 medications, and 44% of older men take more than 5 medications. In the category of more than 10 medications is 12%. But this study is from 2002, the survey, so these numbers could be much higher now. It's also important to think about that while, for the most part, when you hear the word polypharmacy, this is a negative term. But there's going to be instances where polypharmacy is appropriate. For example, you have a patient with ejection fraction of 25%, they have reduced ejection fraction heart failure. So that's going to be, it's going to be normal for your patient to be on at least 5 medications. They're going to be on goal-directed medication therapy, right? So in that case, polypharmacy may be appropriate. So I just want to make that caveat as we move forward. In 2015, the National Center for Health Statistics looked at some data, and they found that 42% of patients greater than 65 years old used 5 or more medications in the last 30 days. So this is a common scenario where your older adults, as your patients age, the number of medications they're going to be using is going to be increasing. So polypharmacy, and it's no surprise, and even though this is the first time you've had a grand rounds on this topic, many of you are already familiar with the consequences of a patient being on too many medications. It can lead to increased adverse drug events. It can lead to prescribing cascades, which I'm going to talk a little bit more about in the next few slides. It can increase the risk of drug interactions. And as our patients take more and more medications, that's going to increase the risk that they might be non-adherent. And this is especially true in our patients with visual and cognitive impairment. And so then all of these things that are happening because of polypharmacy can then lead to increased emergency room visits, increased hospitalizations, increased cognitive decline, and decreased physical capability, and death can be a consequence of polypharmacy. And all of these things can increase healthcare costs to our system. So polypharmacy, it is, if you can tackle polypharmacy, you can avoid a lot of these negative sequelae. So I want to illustrate what I mean by a prescribing cascade. And we developed these slides for a 5-module Coursera course that I'll talk to you at the end of this presentation. But what a prescribing cascade is it occurs when an adverse drug event is misdiagnosed as a new condition, and then the patient is given a drug to treat that mistakenly called new condition. And that goes on and on. So this can put a patient at risk for multiple adverse events, which then would result in them getting another medication, which then can be a continuous cycle. So this is how polypharmacy happens. So if I gave you an example of amlodipine, amlodipine may cause the side effect of pedal edema. If someone is not aware of that and they think this edema is due to something else, they might prescribe the patient furosemide, which then may cause hypokalemia, which then may result in them receiving a potassium supplement. So you'll always want to try to avoid a prescribing cascade by first asking if that initial medication is warranted. Is there an indication for it? This is a study I found looking at a prescribing cascade, looking at gabapentin, which was prescribed for patients with low back pain. And what they found in this population-based cohort study is that patients prescribed gabapentin were more likely to receive a diuretic for gabapentin-induced edema. And you can see the stats here that were statistically significant. So you can see the data here at 90 days, 2% of the patients given gabapentin were prescribed a diuretic versus 1.4 for those who did not get anything. And that at 180 days, gabapentin patients were prescribed a diuretic. Now, yes, you can look at the absolute risk difference and say, oh, it's really not that different. But what is different is that these patients got an additional medication. Now they have Lasix on their medication list. So that's one more drug that they possibly didn't need. And so what you would do as a provider, you would look back and say, why is this patient on gabapentin? Is this the best choice for this patient's low back pain? Which we know which may not be the best choice for this patient. So then what's the definition of deprescribing? And this is really the process of trying to decide whether you should stop a medication or taper it and reduce the dose. And there are multiple considerations to think about, and many of these we've just talked about these. The AGS has said that these are part of their guiding principles, right, for prescribing in older adults. So we want to think about indication. Is there an indication for this medication? Does the harm outweigh the benefit? What does your patient want? What do they value? And what is their life expectancy and time to benefit of a particular medication that you're looking at? Now, this is a study that just an example of a myriad of studies on deprescribing. There is a lot of evidence out there that deprescribing is possible. This is one example where the VA developed a deprescribing tool called Vione, and they implemented it across all of their VA sites. So they developed this tool, and this image is a little bit difficult to read, but V stands for vital life-saving medications. I is, does this drug improve quality of life? Is it important? O is that this drug is optional. There's really no impact this drug has. N is it's not indicated, and E is every medication has a diagnosis. And what they found by implementing this tool, it benefited 60,000 veterans. They deprescribed 130,000 medications, and they had an annual cost avoidance of $4 million. So this is just one example of how one institution health system, instituted a deprescribing tool. Now let's look a little bit deeper into the different types of tools that you can use to help you deprescribe. I'm going to first talk about my hierarchy of medication evaluation. We'll talk about BEERS, the start-stop criteria, the medication appropriateness index, and the choosing wisely framework. So I developed this hierarchy to really help nurses, physicians, any provider, any learner, to help them when they're trying to approach a patient's medication list. And I developed this similar to Bloom's taxonomy, with the most basic information at the bottom of the pyramid. And as you go up the pyramid, it requires more complex and critical thinking. And so at the bottom of this pyramid, this is what I call baby pharmacy. And so here you're just wanting to know if the drug has an indication. Is there a reason why this patient's on it? And so if we use the example of amlodipine 5 milligrams daily, I'm looking to see if this patient has hypertension. If they do, great, no problem. I can move on to the next level. The next level is still what I consider baby pharmacy, and that's just looking at the dose. Is the dose appropriate for this patient's renal status, their hepatic function? Do I need to renally dose a drug? And so when I look at amlodipine 5 milligrams daily, it doesn't need to be renally adjusted, so we're good. So we can continue on. The next level of this hierarchy, and it's, to me, this is one of the most important questions that you need to ask when you are prescribing or when you're looking at a patient's medication list. And that is, before I write this prescription, before I make this order, before I approve this order, is there any reason why I should not give it? Okay, asking this negative question will help you come up with a very short list of, that means you're thinking about contraindications, black box warnings, any major side effects that is known to occur with this particular medication. I find that asking this negative question is much easier than asking the positive question. If I ask who should get amlodipine 5 milligrams, that's an infinite list. But if I say who should not get it, then I'm just thinking about patients pretty much who have pedal edema. So if I look at my patient, they don't have pedal edema, no problem, we're good to go. Amlodipine 5 is appropriate in this patient. So asking this negative question is really important. And then when you get to the top of this pyramid, this is where we're looking at appropriateness. Is this the best choice for this patient that's sitting in front of you? What's the gold standard of care? What's the evidence? You want to think about effectiveness. Can the patient afford this medication? Will they even take it? Okay. So when you get to this point, if we're using the example of amlodipine 5 milligrams daily, and they just have hypertension, then you're good. It's appropriate, no problem. Go ahead and order that medication. But if I change the scenario and tell you that the patient has an ejection fraction of 25% and they have reduced ejection fraction heart failure, then we know that the best choice for this patient really is an ACE or an ARB. Okay, so at that point, in this scenario, amlodipine 5 is not the best choice. So you can see you may pass through all of these levels, but when you look at your patient's situation and individualize it, that drug may not be appropriate. And so you'll want to think about all throughout this process, you want to think about all the multimorbidities the patient has when using this tool. And so this becomes second nature. You will automatically ask yourself, who should not get this drug? I think if you only remember that part of it, you will prevent inappropriate prescribing. Now, the next tool that you can use to help you deprescribe is Beer's criteria. Many of you, I'm sure, have heard of Beer's criteria, but this is really the Bible that we use in geriatrics. And this is a guideline that helps you identify what drugs are potentially inappropriate in older adults. Now, I say potentially inappropriate because are you going to see an older adult who's going to CT get Ativan before they go for the procedure? Yeah, you might see that. But in general, as a whole, these are drugs we really want to think about as red flags. And so you will see many medications such as benzodiazepines on this list. You will see anticoagulants such as DOACs on this list. But it provides guidance and a rationale for why these medications may be problematic in our older adults. Next, I'll talk about the stop and start criteria. This is there are two documents, there are two versions. The first version came out in 2008, and then it was updated in 2015. But this is a document, another explicit document that gives criteria for what drugs should you stop, what drugs should you start in an older adult. So if we focus on examples of drugs you should stop that's mentioned in this document, for example, don't give an SSRI to somebody with a history of severe hyponatremia, or don't give hydrochlorothiazide to somebody with severe gout. So they have a long list in different disease state categories of drugs that you should stop or discontinue or deprescribe. And there are many studies that have looked at this criteria, and stop meds that were stopped based on this criteria within 72 hours have been shown to decrease adverse drug reactions. And it's really been shown to improve medication appropriateness in hospitalized older adults. So like I said, there are two versions. The newer version kind of updated the medications that were described in 2008. This next tool is called the Medication Appropriateness Index. This is a 10-item questionnaire. This is a more implicit criteria-based index where you would use your clinical judgment by asking in some form these 10 questions to your patient and reviewing this. And it's often used as a research tool, but this is a tool to, again, help you identify inappropriate medications in older adults. And then this last item I want to talk about here is the Choosing Wisely framework. And this is an initiative of the American Board of Internal Medicine Foundation that started in 2012. And it was meant to spark conversations between patients and their physicians and their providers. And they partnered with multiple medical pharmacy organizations, for example, the American Society of Consultant Pharmacists, the American Geriatrics Society, and they provide recommendations for practices to avoid. For example, don't give more than 3 CNS drugs at a time to an older adult. Don't use antipsychotics as first line to treat behavioral disturbances in a dementia patient. So there are multiple organizations, medical organizations, that came up with their choosing wisely criteria. So this can also help guide appropriate prescribing. So it's helpful to think about what are the high-risk drugs that these guidelines talk about. And this is a list of drugs that you should think about as red flags in your older adults. And so anyone on opioids, benzodiazepines, psychotropics, antipsychotics, NSAIDs for sure, anticoagulants, digoxin, cardiovascular drugs, because we're looking at especially drugs that obviously we're worried about syncope and hypotension, hypoglycemic agents, and anticholinergic drugs. So you will see, if you review any of the tools that I discussed just now, you will see all of these drugs talked about in those guidelines. So there is an actual process of prescribing that is discussed in the literature. And again, you can see this is the same principles that we've been talking about. But what is the patient taking? Make sure you look at harm. Okay, look at high-risk drugs, look at cognitive impairment, look at their functional status, look at multimorbidity. Ask yourself, is it possible to stop this medication? Maybe there's no indication. Maybe it's part of a prescribing cascade where the initial drug is not even needed. We'll talk more about harm versus benefit. Maybe the drug's not even working, or maybe the patient's better, and now we can stop the drug. The time to benefit is not advantageous to the patient. The patient's not going to they're not going to live long enough to see the benefit of the drug. And we'll talk more about this. The drug imposes an unacceptable high treatment burden. Now, you'll want to prioritize drugs to discontinue. So you want to think about low-hanging fruit, like see which drugs you think are the easiest to deprescribe, because your patient's going to have to agree to it. So maybe your patient's going to offer up like, okay, I can stop my PPI. And so you'll want to prioritize what you want to start with. And then you want to implement and monitor your plan. So this is a really great example of thinking about harm versus benefit. This is the ASCEND trial. I don't know how many of you remember the ASCEND trial from 2018, but this was a study looking at aspirin for primary prevention in diabetic patients. And their primary outcome was looking at any serious vascular event or revascularization. And what they found was that aspirin was very effective in reducing the primary outcome. It showed 12% less events with 100 milligrams of aspirin daily in diabetic patients. And this is over 7.5 years. But the absolute risk reduction was only 1%. So it was really small. But when you look at the harm outcome, they were looking at major bleed. And aspirin at 100 milligrams daily showed a 30% increase in more bleeds versus patients without. So this is a perfect example of where, yes, the drug is really effective, but the harm outweighs the benefit. And this is a particular issue, the bleeding in our older adults. And so I wanted to share this study with you to illustrate that. Now, when you're thinking about harm versus benefit and deprescribing, you can think about drugs in two kinds of categories. One are drugs that are for symptoms, okay? And so sometimes, like for example, levothyroxine diuretics, analgesics, your heart failure medications. You know, sometimes these drugs are crucial for a patient's quality of life and symptoms. And so you may decide to not deprescribe those drugs. It would depend. And so you would have to look at your patient and how effective the drug is. You can also look at preventative medications like bisphosphonates, statins, and aspirin. And these are classic examples we use in these kinds of talks where, for example, bisphosphonates, we know that if you stop bisphosphonates after 5 years, they're still going to achieve benefit in the reduction of non-vertebral fractures. They don't see that patients are getting more of those after they stop the drug. And so wouldn't it be great if you could stop somebody's alendronate and then they don't have to deal with the onerous administration instructions and adverse effects that are that are associated with bisphosphonates. When you look at statins, we know that the time to benefit for primary prevention for statins is 2 to 5 years. Is your patient going to live that long to achieve that benefit? And then I just show you an example of aspirin. So this is I next want to talk to you more about life expectancy and goals of care. And this is a graph that we've adapted from the Holmes paper in Archives of Internal Medicine in 2006. But this is a model of concepts that we should consider when making medication decisions in our older adults. And if you look at this graph, it's showing you the relationship between life expectancy on the bottom and goals of care, which is this green bar. So if we have a patient whose life expectancy is long, you have a healthy patient, very few disease states, then we expect that their medication options, they would fall here on the right side of this graph. They would have many options, and that their treatments are usually going to be curative. You're going to be aiming for a cure. But if you have a patient with a short life expectancy, looking here at the left-hand side of this graph, then, and their health is declining, then their medication options are going to be much fewer, and your goal of treatment is probably going to be more focused on symptomatic relief. So it's important to keep this model in mind as we care for our older adults. So again, with life expectancy, will the patient live long enough to achieve the benefit of the medication? And again, and time to benefit. How long is it going to take to achieve benefit? Now, this is where knowing the literature, knowing the evidence is going to be required in order to determine this. You want to think about the goals of care. What does your patient care about? What do they value? What do they want? And what is the treatment endpoint that you and the patient are seeking? Is it symptom treatment, symptom management, or is it cure? Now, this is a table I've put together with some common agents when we think about time to benefit. And again, this requires knowledge of what the evidence says for a particular treatment. So for bisphosphonates for osteoporosis, we know the estimated time to benefit is 8 to 19 months. As I mentioned before, primary prevention for using statins is 2 to 5 years. Aspirin for primary prevention is 10 years, and intensive tight glycemic control for diabetes is 10 years. So it's very helpful to know these time to benefit numbers, because then you can look at your patient, individualize it to them, look at their life expectancy, and determine if the treatment is worth adding or not. So what you can do is that at every encounter with your patient, you want to review their medications and see if they're having any issues with them. Are they having adverse effects, unwanted reactions? Are they having administration problems? Is it working? Is it effective? If it's not working, then maybe we can stop it. And so you'll want to ask your typical normal questions when you're doing medication review. You can use the tools that I've shown you today, the start-stop criteria, Beers criteria. You can use my hierarchy to really think about, help you target those high-risk drugs in your patient. You want to think about harm versus benefit. And then I've provided you with 3 really great websites on deprescribing. These are the premier organizations that are leading the charge in research in deprescribing, and they've created many algorithms for deprescribing. So that you will find deprescribing algorithms for PPIs, for benzodiazepines, and a whole host of other high-risk medications in older adults. So when you get down to the last part, you've agreed on a drug to deprescribe, and now you want to implement your plan and come up with a monitoring plan. So make sure that your patient is on board. And that's going to be the biggest challenge, as Dr. Delahose had mentioned to me about your patients, in terms of how difficult is going to be to get them to agree to stop a medication. Try to stop one drug at a time, and taper medications that are likely to cause withdrawals, for example, benzodiazepines or acetylcholinesterase inhibitors. Make sure you communicate that plan to everyone, all of their providers, document it well in the chart, document the reason why you're deprescribing, and let your family, the family and the caregivers and the pharmacy know that this drug is being stopped. We saw a patient this week who told me that when she brought in all her bottles, they were very confused because their pharmacy keeps automatically refilling all of the medications, and they don't necessarily need them because they still have enough at home. And so it's just adding to their pile of medications and adding to the confusion and causing more and more polypharmacy. So make sure you communicate this plan to all involved. Now, yes, it may be, we may think that it's going to be difficult to convince our patients to deprescribe, but actually it's definitely possible. And this is a study looking at the attitudes of deprescribing in older adults. How did older adults feel about their medications? And this is very interesting in that they 42% said they take a lot of medications. 67% said they want to decrease it. And 90% said, if my doctor told me to stop it, I would definitely stop it. So this is all great. But then 90% also said, I believe all my medications are necessary. So this is a clear contradiction, but it provides an opportunity for you as the prescribers to have that conversation, because clearly the patients are ambivalent. They know they take a lot of medications. They're willing to stop if they have that conversation with you, and hopefully that can decrease the large number of patients who believe all their medications are necessary. This kind of indicates that patients might not understand. They might not understand why they're taking their medications. Maybe it's just because my doctor prescribed it, or do they truly believe that it's necessary? So having that conversation with your patient really can flip them the other way, because clearly patients are thinking about it and they do recognize that they take a lot of medications and they'd like to take less. So I'd like to finish up with a few cases to illustrate the concepts that I've talked about this morning. This is a case of a 78-year-old male with poorly controlled diabetes, gastroparesis, hyperlipidemia, depression, osteoarthritis, and he came in with worsening tremors and involuntary twitching in his face. On exam, he had some mild epigastric discomfort, and he had some oral and facial dyskinesias and foot tapping. So there was this working diagnosis of Parkinson's disease in this patient, and the urgent care clinician prescribed carbidopa-levodopa. You can see his medications in my little prescription pad here on the right. He was on metformin, sitagliptin, metoclopramide, atorvastatin, sertraline, and acetaminophen. So why is this a problem? What's happening here? So in this patient with diabetes-related gastroparesis, he was probably given metoclopramide to deal with that. And after taking it for many, many years, he developed tardive dyskinesia and dystonia from the metoclopramide. And now he presents in the urgent care with these symptoms. So he's diagnosed with Parkinson's disease and is given carbidopa-levodopa. And then what could happen? Now we're in this prescribing cascade where now he may develop orthostatic hypotension. And because of that, then he's prescribed midodrine. And this is where in the hospital, we see patients on midodrine, and this definitely could happen. And so I think this is a good example to show you what a potential prescribing cascade could look like in a patient. So what would we do with this patient? You would need to think about some other ways to treat the gastroparesis to stop the incident drug, stop the metoclopramide, and then you wouldn't need the carbidopa-levodopa. Could they change their diet? You would have to talk about other options, but really there's no great options for this patient. Maybe surgery, but you would have to discuss that. And if they did develop orthostatic hypotension for some other reason, you could manage that non-pharmacologically. This next case is actually a case that came to our service. She was an 83-year-old woman who was admitted to the hospital for hypoglycemia. She actually fell at home and was found by her daughter, and she had altered mental status and very low sugars. So she has type 2 diabetes, dementia, dyslipidemia, a whole host, lots of comorbidities. Now, it was very unclear what her insulin history was. She was last discharged from the hospital on glargine 12 units and Lispro TID, so she was on basal bolus at home on discharge. And then when she went to the SAR, she was given 70-30 twice a day. We don't know if she checks her sugars, so it was kind of a mess. So what's our assessment here of her regimen? Well, first, what happened was we got an endocrine consult, and endocrine came in and they determined that her home meds were glargine 12 units at bedtime and Lispro 3 units around meals. So their recommendation was to change over to sitagliptin 100 daily and repaglinide 4 milligrams daily. So when I came in that Monday morning, I looked at this regimen. I thought, okay, I'm thinking in my hierarchy. I'm thinking, is this the best choice for this patient? That's the top of the pyramid here, right? And so the first thing I want to think about is, what's her A1C goal? So I went to look what her A1C was, and her A1C was 6.5%. That's pretty good, right? And so I asked myself, all right, well, what is the standard of care? What is the goal for this 83-year-old patient with multimorbidity? Okay, so I look at the standard of care. And so I go to the American Diabetes Association, I look at their standards of care, and you can see that they look at health status, and then they make a recommendation for what a reasonable A1C goal is. And so when I look at this chart, I feel that this patient falls in the complex intermediate category. She's got cognitive impairment, she has depression, she has COPD, she has hypertension. And so really her goal is less than 8%. Okay, well, she's already there. She's way below that. She's at 6.5%. Okay, so this helps me make an assessment of the recommendation made by endocrine. So really, the most appropriate regimen for Irma is nothing. She doesn't need anything. She is well below her goal. And we don't even know she's really taking her insulin. So in this example, we are using current evidence to and individualizing it to our patient. And because she has complex illness, her goal is much higher. And then this last case is to really illustrate the concept of time to benefit. This is an 80-year-old female who comes to our clinic for regular checkup, and her doctor says that her cholesterol is high and wants to start her on atorvastatin 40 milligrams daily. She's never had a heart attack, so this would be primary prevention. And her e-prognosis calculation is a 50% chance of living 1 year. Her home health aide assists with her activities of daily living, like bathing, and her instrumental activities of daily living, like shopping and cooking. You can see her past medical history. She's got mild dementia, COPD, heart failure, end-stage renal disease, and diabetes. So she comes to clinic asking, do I really need atorvastatin? You know, I'm so sick of taking so many medications. Is this really going to help me? You can see her medications here. She's already on metformin, metoprolol, lisinopril, furosemide, and for her heart failure, and sevelamer 3 times a day. So what do we need to think about to answer her question? So I'll just show this slide again to remind you that we want to be thinking about life expectancy in relation to goals of care and asking these questions. Will she live long enough to achieve the benefit of the statin, of atorvastatin? How long will it take to show benefit? What does she want? And she's been very clear about what she wants. And what is the treatment endpoint you seek, or that results from this? So if we look at Gloria, we know that based on her e-prognosis calculation, her life expectancy is 1 year. We know that the time to benefit is 2 to 4 years for primary prevention if you gave her atorvastatin. So that puts her over here. What are her patient values? What are her goals? Well, she told you she's tired of taking all these medications and she just wants to focus on what she's taking right now. So then her treatment targets really would then be symptom management. So keeping her furosemide for her heart failure would be completely appropriate. But there really is no need to start her on a statin based on this information. Now, so therefore, we don't need to start the atorvastatin. And in geriatrics, we have what are called the 5 M's, and this really addresses medication and what matters most. Now, please note that the decision to start or stop a medication is not based on numerical age. If Gloria had a family history where her relatives lived to be 100 and she had no chronic disease, then it might have been appropriate to start atorvastatin because she would definitely live long enough to at 2 to 4 years to achieve the benefit of atorvastatin. So starting or stopping a medication is not dependent solely on a patient's age, as we've illustrated here. So before we conclude, I wanted to share a study that I am working on with Dr. Fred Koh and William Hung, and we are looking at polypharmacy and deprescribing in World Trade Center responders. And this is part of the larger study, the Promoting Healthy Aging Among World Trade Center Responders, the frailty study that Dr. Koh had spoken about in December. And this is a deprescribing study that we're working on right now. We're looking to enroll 50 World Trade Center responders. And this study is going to include both World Trade Center prescribers and non-World Trade Center prescribers. There will be no programmatic changes to the World Trade Center Health Program. Nothing is going to change about that. But what we are looking at is we're targeting 5 drug categories. And we're going to be, and that would be first generation antihistamines like Benadryl, proton pump inhibitors, benzodiazepines, Z drugs, and muscle relaxants. And so what we're looking at is we have created patient education materials that we will be sending to patients and their prescribers. And our goal is to really help facilitate a conversation between the prescribers and the patients. And that may result in deprescribing. And so this is a pilot study that's ongoing. We're right in the middle of it, and which is why we're here today to really talk to you a little bit about the concept of deprescribing and polypharmacy, so that if we were to reach out to you or you were to receive a communication from us, you'll have an idea of what we're talking about. So in conclusion, polypharmacy is very common in older adults, and it's going to increase as your patients age, and it can increase mortality and morbidity. So deprescribing can reduce polypharmacy side effects, costs, because we're basically eliminating medications that they don't need anymore. And I talked about different tools you can use to help you target these medications and really improve your prescribing habits and try to avoid inappropriate medications. And so that you could use Beers criteria, the start-stop criteria. You can use my hierarchy to reduce polypharmacy and inappropriate prescribing. And all the while you're doing this, you want to consider multimorbidity in your patients. Think about their patient values, what they want, and time to benefit when you are deprescribing in your patients. If you want more information on rational prescribing in older adults, I, along with Dr. Martine Sanan and Dr. Ravi Ramaswamy in the Department of Geriatrics and Palliative Care, we created a 5-module Coursera course for the medical school. And it's called Responsible Medication Prescribing for Older Adults. I've put the link here for you. This is completely free for anyone who wants to learn more about how to be a better prescriber in older adults. And again, this is a 5-module course, and it went live in November. So that's free for anyone to take. I want to thank the Mount Sinai instructional group. Some of these slides are in the Coursera module, and they helped us do the illustrations for some of these slides, and Dr. Ramaswamy, who some of these slides are from his presentation. So thank you so much.